very excited to welcome on Natalie Pettit to talk about her emergency medicine clinical pearl. Now, Natalie is an emergency medicine pharmacy resident at the University of Illinois Hospital and Health Sciences System. Natalie, hello, welcome. How are you?
Hi, Nick. I'm good. Thank you.
One of our most common antidotes, right, when we use for opioids specifically is naloxone. And despite the common thought that this agent is without adverse effects, I'm excited for Natalie to go into detail on one that's going to take our breath away. So the floor is yours.
Yeah, thanks, Nick. I thought I'd get the conversation started with a patient case that got me interested in this topic in the first place. So, starting with patient LH is a 34-year-old female brought to the emergency department by EMS for altered mental status in the setting of suspected opioid overdose. The patient was found unresponsive at home by a roommate with slow respirations, pinpoint pupils, and a suspected history of heroin use. EMS administered a total of 4 milligrams of intranasal naloxone in the field, and the patient responded, becoming more awake and was alert and oriented to person in place. On arrival to the ED, the patient developed worsening mental status with an ANO times 0, respiration rates of 6, and was then given an additional 0.4 milligrams of IV naloxone and developmental status improvement and respiratory rate improvement, saturating well on room air. About 1 hour later, the patient then developed acute onset tachypnea with worsening saturations down to 84% and was noted to have frothy sputum in her mouth. Her vital signs are as follows: blood pressure 125/85, heart rate a little tachycardic at 115, respiratory rate of 30, O2 saturation 84% on room air, and was afebrile. The patient's physical exam was notable again for pinpoint pupils, bilateral crackles in all lung fields, did not have any peripheral edema, and had strong pulses. She was ANO times 2 and able to follow simple commands. Her labs, CMP, CBC, and troponins were all within normal limits. The EKG demonstrated sinus tachycardia, and her urine drug screen came back positive for opioids and benzos. So moving on to our discussion of what the heck is happening, starting with naloxone. We all know naloxone as our non-selective opioid antagonist, binding to mu opioid receptors in the central nervous system and reversing the respiratory depression and sedation caused by opioids. This medication was approved by the FDA in 1971 and comes in a variety of formulations and can be given a variety of different ways, including intranasal, intravenous, intramuscular, via endotracheal tube, nebulization, and sub-Q administration. In recent years, we've seen it increasingly used in the pre-hospital setting to reverse opioid-related overdose and prevent fatal death secondary to opioids. Here in Chicago, in addition to over-the-counter naloxone for purchase, we have public accessibility via a bunch of vending machines located throughout the city with intranasal Narcan, which is pretty cool. Naloxone's onset is pretty fast, in about 1 to 2 minutes, and lasts for about 30 minutes duration. Going to the package insert with our adverse effects of the medication, we all know it can precipitate opioid withdrawal, which is the point, but can look like nausea, vomiting, sweating, tremulousness, and tachycardia. Can also precipitate pain for our chronic pain patients. And notably, it's mentioned in the package insert is pulmonary edema, which again is why we're here. So this is a rare but potentially serious consequence of naloxone administration that has been reported in case studies and case series in the literature. While in our mind is not a reason to avoid naloxone, this is a rare but serious side effect that has been reported and has driven a lot of curiosity in investigators in the healthcare setting. One of the first reported cases of this naloxone-induced pulmonary edema phenomenon is from 1977 by authors Flackey and colleagues. titled Acute Pulmonary Edema Following Naloxone Reversal of High Dose Morphine Anesthesia. And this case describes pulmonary edema post naloxone used to reverse morphine that was used as the anesthetic in a cardiac surgery case. Now, authors discussed the proposed mechanism of this phenomenon and suggested a catecholamine surge. So I'd just like to go now into the proposed mechanisms of naloxone-induced pulmonary edema. Many theories have been proposed to describe what's going on. However, this largely comes from retrospective studies and case series and reports. So looking at kind of a breakdown of the mechanisms, we'll start with addressing naloxone itself first. So naloxone is thought to act centrally and cause a massive catecholamine response from precipitated opioid withdrawal or sudden cerebral recognition of hypoxia, leading to a dramatic shift of blood volume into the pulmonary vascular bed, resulting in increased hydrostatic pressures, which shifts fluids into the lung interstitium and results in pulmonary edema. The next proposed mechanism has to do with the opioid on board itself. So we all know opioid overdose can cause pulmonary edema, and this mechanism is thought to be multifactorial, relating to histamine release, prolonged hypoxia, and acidosis in the setting of respiratory depression that leads to increased pulmonary vasopermeability and subsequently pulmonary edema. A case report to describe this mechanism comes from Sporer and colleagues, published in Chest in 2001. And this was a case series describing opioid-induced pulmonary edema at rates of 2.1% post-naloxone administration and described the opioid-related mechanism. The timeline they noted from this phenomenon was 1 to 2 hours post-naloxone treatment, and resolution of the pulmonary edema resolving in about 48 hours with supportive treatments. A third mechanism is more physical and has to do with the negative pressure in the lungs resulting from inspiration against a closed glottis. And finally, this is maybe not with pulmonary edema itself, but pulmonary complications resulting from opioid or naloxone use, including pneumonitis and aspiration pneumonia secondary to the opioid overdose. Now, noting all four of these different mechanisms, it's often difficult to differentiate between the mechanisms at the time of presentation. So it's often a diagnosis of exclusion once you see the patient through their stabilization. Other differential diagnoses of presumed opioid-induced or naloxone-induced pulmonary complications include, again, the aspiration events secondary from opioid withdrawal and any underlying cardiogenic pulmonary edema or additional potential agents at play, for example, like a cocaine co-ingestion. The clinical presentation of patients experiencing naloxone-induced pulmonary edema, they'll present with dyspnea secondary to impaired gas exchange, tachypnea, cough, tachycardia, pink or white frothy sputum in the mouth or airway, crackles on lung auscultation, and in severe cases, cyanosis. Pulmonary edema is diagnosed through radiographic imaging, including chest X-ray or chest CT, which will show fluid accumulation in the interstitial spaces of the lungs. So moving into risk factors. So who is at risk for this naloxone-induced pulmonary edema phenomenon? And I'd like to break it into 3 different buckets, including patient-specific risk factors, opioid-specific risk factors, and finally our naloxone-specific risk factors. So starting with patient-specific risk factors, again, patients with underlying existing heart failure or pulmonary comorbidities are at risk for pulmonary edema at baseline. And we like to think of these patients are older patients with pulmonary or heart complications. However, when describing the naloxone-induced pulmonary edema, this has been reported in younger populations, including pediatric patients to young adults who, in our minds are less likely to be at risk for those underlying pulmonary or cardiogenic complications. A case in a 3-year-old was published by Grout and colleagues in 2022, again describing a case of naloxone-induced pulmonary edema in a 3-year-old who had an accidental opioid ingestion. The patient's chest x-ray post-naloxone administration showed pulmonary edema, and the patient received a total of 2 doses of naloxone, each 30 minutes apart at a dose of 0.1 milligrams per kilogram. And they did not attribute the findings to any other reason other than this naloxone-induced pulmonary edema. Moving into our opioid-specific risk factors, again, although not confirmed, the thoughts are that our longer-acting opioids, such as methadone or extended-release oxycodone or morphine, and our more potent opioids, including fentanyl, are put the patient potentially at risk for this phenomenon. And in recent years, there has been a shift to fentanyl in the illicit drug supply, which maybe represents why this phenomenon has been more reported in the literature as of late. Finally, moving into our naloxone-specific risk factors, and the one that I think pharmacists are more excited to discuss, answering the question, are higher doses of naloxone associated with increased rates of pulmonary edema? And there aren't many high-quality research studies looking into this question, but one of the best available was published by Farkas and colleagues in 2020, seeking to answer if this is a dose-related phenomenon. So again, this was published in 2020 in Annals of Emergency Medicine, and their aim was to assess if higher doses of naloxone administration in the out-of-hospital setting are associated with increased risk of pulmonary complications. And those pulmonary complications include pulmonary edema, aspiration pneumonia, and aspiration pneumonitis. This was a retrospective observational cross-sectional study enrolling patients who received out-of-hospital naloxone and were transported to one of 3 emergency departments within the Pittsburgh area. 1,831 cases met inclusion criteria between April 2013 and December 2016. And the primary outcome, again, was a composite of specific pulmonary findings, which include, again, pulmonary edema, aspiration pneumonia, and aspiration pneumonitis based on radiographic imaging or clinical diagnoses. Authors found that of the 1,831 patients enrolled, just over 25% of them had pulmonary complications secondary to the post-naloxone administration. And about 95% of these cases were diagnosed with aspiration pneumonitis or pneumonia. The authors also looked at risk factors, did a multivariable analysis looking at risk factors for pulmonary complications post-naloxone, and saw that patients receiving more than a total of 4.4 milligrams of naloxone, and those who received a higher dose than 0.4 milligrams of naloxone initially had an over 2 times significantly higher risk of pulmonary complications. And this maintains statistical significance in the multivariable analysis. Other risk factors that authors identified for higher rates of pulmonary complications included intranasal naloxone administration, emesis after naloxone, decreased GCS score before naloxone administration, heroin as the suspected overdose agent, decreased pulse ox before naloxone administration, and an increased pulse rate or decreased oxygen saturation on hospital arrival. Splitting up the pulmonary complications, which is what we are curious about, only 24 of the 485 patients experienced pulmonary edema, specifically not attributed to other causes. And additionally, in those 24, 6 were ruled out as having a secondary cause for the pulmonary edema. So a total of only 18 patients experienced pulmonary edema. This was an interesting finding to me, and I think just highlighting that the occurrence rate of pulmonary edema post-naloxone use is relatively rare, but there are still gaps in the knowledge and understanding of this phenomenon and whether this is a dose-related phenomenon. They were not able to they did not find any significance with assessing dose administration in the patients that experienced pulmonary edema. Additionally, when reviewing published case reports, a clinical toxicology systematic review from pharmacists in Houston highlighted that there are no definite cases of naloxone-induced pulmonary edema according to the Naranjo scale, which assigns causality in the case of an adverse effect to a drug. Moving into management of these patients who experience pulmonary edema post-naloxone, again, largely supportive measures, including supplemental oxygen and diuresis. So going back to our patient case, again, LH, 34-year-old female with presumed opioid overdose who developed pulmonary edema that was diagnosed on radiographic imaging after a total of 4.4 milligrams of total naloxone administered. The patient was saturating at 84% on room air. That improved to 92% on 10 liters via non-rebreather mask. And the patient showed signs of improvement in oxygenation over the next 24 hours with supportive care and diuresis. So some takeaways from this Pearl session is that there are multiple theoretical mechanisms that exist for naloxone-induced pulmonary edema. However, none have been proven. Recognizing that this is a rare but serious potential complication of opioid/naloxone use. However, it's not, again, not a reason to not use naloxone in the setting of opioid-related overdose to prevent fatal overdoses. With significant rates of opioid-related deaths, the risk of not treating a potential fatal overdose with naloxone definitely outweighs the risk of pulmonary edema. And complications of pulmonary edema include potential mechanical ventilation and all the complications associated with an ICU admission or mechanical ventilation itself. And finally, while not completely confirmed, this naloxone administration might have a dose-related effect. So consider using the lowest effective dose of naloxone to reverse opioids. We have some data to suggest that pulmonary complications are dose-related to naloxone, but pulmonary edema itself we still have some more questions to answer.
Natalie, this was awesome. Have you ever seen this before? Because it's one of those, the first time I ever saw it, it's kind of one of those, it's kind of hard to forget.
Yeah, I have seen it before. In a very similar patient case is kind of what I pulled the example from, was someone I saw in the ED, and it was very new to me. And hearing the attendings be like, "Oh yeah, this is naloxone related pulmonary edema," they just jumped to that right away. Um, Not something I learned in school, not something I learned in PGY1, so definitely got me interested.
Well, what a great review on a topic, like you said, that definitely our EM colleagues are familiar with, but clearly there are some gaps in the literature. If we're thinking of creating ideas for research projects, this feels like a really good one. But Natalie, let the listeners know, where can they reach out to you, let you know what a great job you did.
Yeah, I need to boost my social media presence, but I'm on X, I guess, Twitter, Natalie Mostek, I think is my handle. But you could feel free to email me, nataliep@uic.edu with any follow-up questions. Come to the emergency department. I'd be happy to say hi.
Natalie, this was awesome. Thanks again.
Thank you.